Welcome to another episode of Bula Wellness on FBC TV. I am your host, Dr. Neil Sharma. I acknowledge all our viewers from across the country, from the west, the north, the outer islands, and not forgetting the great central and eastern corner of our beautiful nation. This week, we talk about non-communicable diseases or NCDs and its impact on the kidneys. Later on in the show, we've got a guest from the Ministry of Health and Medical Services, Dr. Amrish Krishnan, to share his expertise on the matter. That and more later. Now, NCD-related kidney disease has resulted in much ill health and financial disabilities, and premature deaths in the Fijian communities. 2007 marked the opening of the Kidney Foundation of Fiji in Suva at the CWM Hospital. Hemodialysis was offered as a means to support patients with end-stage kidney disease. Another private enterprise center opened in Nandi for the Western Division patients in 2012 and 13. 2014 saw the opening of the Lambasa dialysis through the Ministry of Health and joint partnerships with the Friendly North Group and the Rotary Club of Lambasa. All three divisional hospitals are equipped to deal with short-term dialysis in their respective jurisdictions as part of emergency care. However, there are no long-term funding to continue this service in the management of the longer-term end-stage disease. There are plans for other centers, such as the new Bar Hospital, under construction. Much research has been undertaken to consider kidney transplantation in Fiji, and the prospects towards it has been undertaken in 2013. Endorsement of the new laws is still pending. After kidney transplant, patients remain on medication to prevent tissue rejection and certain antibiotics lifelong. And these are now also available via the bulk purchase scheme. Today's program hopes to provide general awareness and build on screening measures so individuals can work towards wellness and not end with advanced stages of kidney failure. Life becomes limited around dialysis centers 2 to 3 times a week, blood transfusions, and expensive treatment which only a few can afford.
A master of multitasking inside the human body? And there are 2 of them? Oh, I know, it's the kidneys. For human beings, they're essential to survival. In fact, the kidneys are small biological marvels. They produce urine, thereby removing excess water and toxins, produce hormones, regulate mineral levels and blood pressure, make vitamin D, and maintain the body's acid-base balance. Every day, these versatile organs cleanse all the body's blood, about 300 times. If the kidneys become diseased or fail, it's a serious health problem, because excess water and waste products from the body's metabolism can no longer be filtered out of the blood. To prevent toxins from accumulating, the blood must now be regularly cleansed with the help of dialysis. The most widely used form of dialysis therapy is called hemodialysis. At the center of hemodialysis is a dialysis filter known as a dialyzer. Serving as an artificial kidney, it cleanses the patient's blood during the treatment. Inside a plastic tube 30 centimeters long, about 12 inches, the blood flows through up to 20,000 hair-fine fibers. Microscopic pores in the fibers filter out metabolic waste and excess water, which the dialysis fluid then carries away. As the blood cleansing process proceeds inside the dialyzer, a dialysis machine pumps the blood, administers anticoagulants, and monitors circulation. A treatment can take from 3 to 6 hours, usually 3 times a week. Chronic kidney failure afflicts more than 3 million people worldwide. Most require life-saving dialysis treatment.
We have Dr. Amrish Krishnan from the Ministry of Health and Medical Services as our guest today. Dr. Krishnan is a subspecialty nephrologist, a leading member of the medical team, and has special interest in the service delivery of better kidney health to Fiji. Welcome, Dr. Amrish, and thank you for joining us today.
Thank you, Dr. Sharma. It's a pleasure to be here.
Dr. Amrish, how are the kidneys affected in diabetic cases? Can you shed some light on this, just so that our viewers today can see how crucial this issue is and how important it is to tackle this problem?
Yeah, Dr. Sharma, just to set the backdrop, every year we have about 600 people in Fiji who develop kidney failure. And the studies we did in Fiji showed that about 65% of kidney failure is due to diabetes. So we're looking at about 400 people with complete kidney failure every year due to diabetes. So it's diabetic kidney disease or diabetes-related kidney failure is definitely a big problem. And in terms of how diabetes causes kidney failure, there's some biochemical changes that happen and some hemodynamic changes that happen in the kidney. Just excuse the medical jargon. But what happens is diabetes, long-term diabetes exposure in the kidney produces these chemicals in the kidney, and these chemicals then end up destroying the kidney. I think the other important message there is a lot of times when people with diabetes have kidney failure, doctors are they're quick to label that as diabetes-related kidney failure. But we are noticing that there are people who have diabetes and kidney failure, but where the kidney failure is actually due to something else. So, and the other bit about diabetes-related kidney failure is that you don't get the kidney failure until diabetes has been there for a significant amount of years. We're looking at about 10 years before the damage actually becomes apparent.
Okay. Very interesting, Dr. Amrish. We have to take a short break, but we'll continue after this with more coming up later. Welcome back to Bula Wellness on FBC TV. We have Dr. Amrish Krishnan from the Ministry of Health and Medical Services with us. And today we are discussing NCDs and its impact on the kidneys. Dr. Amrish, how often are the kidneys affected in poorly controlled diabetes?
Thank you. The thing with diabetes-related kidney disease, or in medical terms we call it diabetic nephropathy, it will eventually happen in all diabetics. The differences we're seeing now between people is that in a certain group of people, they have diabetes for a long time and the kidney failure doesn't happen. So you might know of patients who've had diabetes for 30 years or 40 years and the kidney failure doesn't happen. Whereas there's the alternative group, they've had diabetes for only 10 years or 15 years and they develop kidney failure. So there is definitely a genetic element to it, which we haven't been able to pin down. It's probably worth researching in the Pacific. But the studies abroad, they show that early good control of diabetes leads to the delay in the way the kidney failure sets in. Okay. And the study showed that those who had poor control diabetes in the beginning, even though later on they had tight control, they still went on to have kidney failure. So the critical part is the early stage of diabetes has to be very, very well controlled.
I think that's well presented, because it tells us that when a diagnosis of diabetes is made, we must look at the kidneys. Patients must address this issue. Yeah. So when diabetes is diagnosed, what should the patient be asking the doctor about the kidneys?
So when diabetes is diagnosed, the thing that the patients and the doctor need to have a feel of is how long the patient might have had diabetes. And that's where the doctor needs to look at other clues in the body which tell us the duration of diabetes. And the first thing that I normally ask patients if they've had an eye check. So if they get an eye check and the eyes show damage in the back of the eyes, the retina, it means they've had diabetes for a long time. In terms of what the patients ask the doctor in terms of how much damage there is to the kidneys, the main things they should ask for is, has the doctor checked the creatinine level, which is the toxin that builds up if the kidneys are not working? And is are the kidneys leaking protein? So the protein leakage in the kidney is the earliest marker that diabetes is now starting to affect the kidneys.
Good. Okay. Now we'll just take a little angle of this and come back to this in a moment, because I think this is very important. Is there medication or other measures to reduce end-stage kidney disease?
So when we look at, so if it's a general question on end-stage kidney disease, yes, depending on the cause of the end-stage kidney disease. If it's diabetes related, there are certain medications I'll mention in just a bit. But if it's not diabetes related, then depending on the cause, there may be certain medications. So if it's what we call autoimmune disease, where the human body is damaging the kidney itself, there are certain treatments, we call them immunosuppressive medication. But moving on to diabetic kidney disease, unfortunately, no medicine will cure diabetic kidney disease, but there are medications that that delay the progression of disease, and we call them the ACE inhibitors or the ARBs, or angiotensin receptor blockers. And the one that's available in government is enalapril.
Enalapril. Yeah. Thank you. Are there special tests to keep a closer watch on kidneys, as in other developed countries?
Yes. The good thing about diabetes kidney disease, the tests to find out if you have involvement of the kidneys are very simple and fairly cheap. So, creatinine is, costs less than $5 to run. So we know, we can tell if the kidney function is affected. But apart from that, checking the urine for protein leakage. Now, there are different ways that you can check for protein leakage. The simplest method is you doing a urine dipstick. And, that's probably less than 50 cents a dipstick. So you do a dipstick and you see if there's any protein leakage. The more accurate way of actually measuring how much protein is leaking in a diabetic is to measure what we call the urine ACR, or the albumin-creatinine ratio. So this microalbuminuria is now the very first marker that the diabetes is now starting to hit the kidneys. And in fact will exist long before the creatinine becomes abnormal.
Sure. How close are we to making hemoglobin A1C and microalbumin widely available in our diabetic facilities?
Hemoglobin A1C, or HbA1c in short, is already available in all the major laboratories in Fiji, in the divisional hospitals, and I think there are certain subdivisional hospitals that are able to do it as well. Ideally, we want to roll this to, even at the health center levels, but that's something that the ministry will be looking into. In terms of access to the microalbumin testing, the WHO recently, or they are in the process of promoting the PEN program, and which is looking at the things that you can test for early detection and better management of diabetes. And I met them recently, and I said that microalbumin testing should be something that should be incorporated in the context of our economy.
Okay. Yeah. Because way back in 2009, 2010, the lab equipment for hemoglobin A1C and microalbumin was circulated to all subdivisional hospitals, but for some reason or the other, reagents have never been available, and it's unfortunate that it's not being used, because a large percentage of our patients could benefit.
Yes, and on that note, Dr. Sharma, it's one thing to have the testing available, and the other thing is to actually educate the health professional to utilize this testing. And that's something that I've been trying to do through the conferences we run, is for them to have a feel, to know that microalbumin testing is important.
Do we have the ability to offer renal transplantation in Fiji in the not too distant future, with all the operating theatres now ready and commissioned at CWM Hospital, and the new laws ready for implementation?
So kidney transplant, again, is an area that's quite close to my heart, but when you're looking at transplant, you have to look at all the other logistical bits that need to be in place. And we need to have surgeons, and thankfully we have now 2 surgeons in the country who are trained in the field of urology, which is kidney or urinary tract related surgery. We have 1 nephrologist, and there's another one in training, is just completed now. But the other bits that you need for a transplant process to happen is the laboratory support, where they can do the tissue compatibility, your intensive care service, in which we do have a very good intensive care unit, and trained nurses, so who know about care of patients post-transplant. And then, as you mentioned, the medications to the accessible medications to make sure that they don't undergo rejection. So we're almost there. I think the gaps that exist at the moment is our laboratory. We need to upskill our laboratory staff to understand and know how to do the tissue typing or the tissue cross-match. And so it's a dream, but it's an achievable dream. And I think that if we work hard at it, within the next few years, we should be able to do the first transplant in Fiji.
People often ask, why is there such a cost disparity in the dialysis treatment offered in Suva compared to that in Lambasa?
Yeah, and again, when you look at the cost, you have to think about what makes dialysis so expensive. And the machine itself is expensive to begin with. But apart from the machine, you have the consumables that are used during dialysis. So every set uses, a 5-liter bag of acid. It uses a bag of bicarbonate, blood tubes, the filters, and all these things are single use. You chuck it away. So, and we think that these cost somewhere around $80 or $90 or even $100 per session. So that's just consumable cost. Then you're looking at utilities. So dialysis uses a lot of water. Every session uses somewhere between 150 to 300 liters of water. Then the electricity, the human resource in nursing. And the answer to why there is a gap or there's a disparity between price in Suva and Lambasa is that Lambasa is partially supported by government, where the nursing staff is actually supplied by government. If I'm not mistaken, the utilities are also assisted by the government. So there is some support that the government gives to the Lambasa dialysis unit already, whereas the one in Suva runs purely on its own feet, and therefore the costs are high. But personally, I think that we should all press for reduction in dialysis costs all over the country. And I think if we are smart about how we utilize the resources and cost reduction, we should be able to get the prices down.
Okay. The other issue I would like to raise is the post-transplant and long-term medication being available through the Fiji Pharmaceutical Services, yet patients have not registered for this. What is the reason for this gap?
Yeah, I think at the moment there may be some patients who are not aware of this program, and these are particularly patients who are still in communication with their primary transplant center. So if they've had a transplant in India, they usually maintain contact with the transplant nephrologist, the surgeon in India, who continue to provide medications to them. The other thing is patients will ask, is the cost within the bulk purchasing, is it cheaper compared to what they're getting from India? And I think we just need to promote it. We need to tell them that yes, we're going to make a commitment to make sure that this is a no-profit venture. We'll get the drugs at the cheapest cost. The other bit about anti-rejection medication is the supply must be sustained, and there shouldn't be any gaps in the supply.
Sure. Okay, finally, to sum it all up, what advice do you want to give to our viewers who are watching us tonight?
Yeah, I guess the main thing that I want to give the message to the viewers is prevention. And prevention and early detection is absolutely important. Diabetic kidney disease won't happen if you don't have diabetes. And to prevent yourself from having diabetes, you've got to exercise, you've got to eat well. You've got to make sure that your food is low in the starch and carbohydrate and low in fat. And prevention is the way to go. And particularly exercise is very important. And once you have diabetes, don't be afraid to try and find out if you do have diabetes. So get your sugar checks early. And once you have diabetes, stick with your doctor. Make sure that you're visiting your doctor frequently enough and having those kidney checks done to make sure you don't have failure.
Thank you. Thank you very much for your time, Dr. Amrish. I'm sure everybody watching tonight has learned a lot of new things today. And even if they know this already, it's always good to give them reminders every now and then. Thank you very much.
Thank you.
Welcome back to Bula Wellness on FBC TV. In the last segment, our guest, Dr. Amrish Krishnan, was very direct in his presentation, and we are grateful for that. He highlighted the importance of diabetes leading to kidney failure. Not all cases of kidney failure are caused by diabetes alone. There are other medical conditions which lead to kidney failure too. He emphasized that early diabetic diagnosis must also include an assessment of kidney functions. Some individuals will develop kidney failure within a 10-year period, while others may not. NCD-related kidney disease is not being picked up early enough in our public and private healthcare systems. In fact, there are very few pointers to kidney disease. complicating diabetes until the end-stage disease is advanced and life-threatening. This is the case unless your medical team go looking for these using blood and urine testing methods. It remains your responsibility to ensure that your diabetes is screened, and when a diagnosis is made, ask about your kidneys' wellness. Even in a rushed clinic, tests to determine kidneys being affected by diabetes and other NCDs can be screened in Fiji. Our hospitals have the general pathology laboratory services with technology to screen your kidneys. The relevant authorities need to have reagents available at all times. Our subdivisional hospitals have these machines and reagents. Hemoglobin A1C blood tests and urine microalbumin tests are now the hallmark of screening and follow-up in a lot of countries like Fiji. You as patient, or even as a healthcare provider of your relatives, must ensure that all preventable measures are undertaken. These include eat healthy, moderate-sized meals, low in sugars and fat. Undertake some physical activities for half an hour a day. Monitor your sugar with a glucometer and record your findings. Keep record of what you eat, drink, and how much exercise you undertake daily. Be seen in your clinic regularly. Do not stop treatment when someone suggests alternative treatments. You can add on items from the traditional healers, but continue to record your blood tests as directed by the healthcare team. Talk to the nutritionist or the dietitian at the diabetic hub or clinic, and talk to the diabetic nurse educator to learn foot care. Dr. Krishnan also discussed the options of renal transplantation and the need to ensure its availability in our settings. Our operating theatres and doctors are trained or training, and nurses are in the same situation. The laboratory scientists are also ready to address this development, but the laws on transplantation need to progress into the relevant authorities. International partnerships are ready to support an endeavor, but the relevant authorities need to hasten its progress. Finally, we discussed the price differences in the Suva and Nandi facilities compared to the one set up in Lambasa. Again, it all boils down to public-private partnership in action at the local level. I am confident that the partnership, such as the Madhuwata Lambasa Dialysis Unit, demonstrates that it is possible to do the same on Vitilevu and provide competition to the local private sector entrepreneurs. All kidney transplant patients must register with the Fiji Pharmaceutical Services, and it's possible to get high quality, generic, post-transplant medication at much cheaper rates. There may be private facilities who are not directing patients in the correct route, and the reasons for this may vary. The Kidney Support Group must take note of this and advise their members and the general public. Unfortunately, time has caught up with us again, and we have to conclude our episode here. I am confident you will raise your own and your family's commitment to lead healthier lives. If you have queries about the show or the topic today, you can contact us on Facebook, Bula Wellness, FBC TV, or write to us at bulawellness@fbc.com.fj. Make sure to join us again the same time next week for our next episode. Until then, good night.